Welcome to We the World and our 2025 MLK Manifesting the Dream event. Each year, we take time to remember Martin Luther King Jr. and his beloved community. And each year, we are thrilled to feature the many people and organizations who have taken action to be of service, not only in January and February, but all year round. We at We the World welcome you to take action and be of service at we.net/MLK from January 15th to February 28th. Please join us in being a part of this annual celebration and consider being of service in your communities and with us. Of course, donations are very appreciated at we.net/donate. My name is Yana Larson, and I am the HR and Deputy Director of We the World. Today we have a very fabulous panel, and Thato is our moderator. Thato is from Botswana. She is an entrepreneur and philanthropist and is founder and director of Lemon and Vinegar Ltd. She specializes in the distribution of agricultural produce, machinery, and equipment. With 6 years of experience in livestock and rain-fed crop management, Thato is a qualified horticulture enterprise manager providing consulting and advisory services. She is passionate about building partnerships and engaging stakeholders to develop impactful programs addressing social constructs like age, gender, and race. Thato excels at team building and program construction tailored to a specific event and thematic needs. She is also a longtime We the World volunteer and mother and valued member of our team, and we love her. Thank you, Thato, for being here, and I'll let you take it away.
Oh, Rihanna, thank you so much. I'm so excited for today's panel. Thank you for hosting us and for the warm welcome, as well as to our audience. On today's conversation or fireside chat, will be confronting demographic disparities, examining the root causes of demographic disparities in healthcare, including socioeconomic, racial, and geographic factors. We have wonderful panelists. We have Robert Mwesigye, who's a climate advocate, community leader, and founder of Rejoice Africa Foundation, born and raised in Uganda. Robert has always felt a deep connection to his community and the natural world. Growing up in a rural village, he witnessed firsthand the delicate balance between human life and the environment, an awareness that would later drive his commitment to climate action and social development. We also have Tahsin Bashar, who's a medical graduate and an online volunteer for We the World. We have Lily Liard Ben-Eli, who is a behavioral neuroscience student at Northeastern University on a pre-med track with extensive experience in healthcare, public health, and community service. She's passionate about leveraging her medical expertise, research acumen, and dedication to equity to enhance patient care and advance public health initiatives. Then we have Callum Cintron, who serves as a tribal liaison at Northern Arizona University, where they specialize in integrating indigenous knowledge with Western science. With a background in anthropology and natural sciences, Callum has established themselves as a dedicated advocate for Indigenous rights and environmental conservation. Welcome to this conversation, fellows and fellow changemakers. Let's get into it. This is a question that is going to go to all of you. Many undeserved communities face overlapping crises, economic hardship, environmental degradation, and limited health care access. How can policymakers create intersectional solutions that address these disparities holistically? We'll start with you, Robert.
Yes, policymakers, they need to understand that what they have been doing, it has been targeting them at a centralized level. But if they can include the decentralized system, whereby what they do, it needed to go to the grassroots to solve the real challenge. Because very many people on the ground, they are the one facing the health challenges, but those planning for the policies, they sit in their policy making meetings, gatherings, and they don't come with measures to address the crisis. For example, if a child in western part of Uganda is suffering from malaria, and those people, they sit in New York to discuss how they can help this person, but not listening from this child or the parent what they can use the knowledge from this parent to use in addressing the climate crisis, the diseases in the community, what they can use as a local measure in the sense of addressing the decentralized system of addressing the diseases. Then second, it is equality. Equality. We have we have global south. If we don't consider how these people in global north how they stay, and how these people in global north south how they stay, and the conditions tropical. For example, in Africa we have tropical diseases, malaria and other diseases that are coming as a result of climate crisis. Because if the climate crisis is there, for us, we are most likely to have more effects than those in global north. So if they can define the real positionality of where they are to address the climate crisis, it is going to be the well target to address those things.
Thank you so much. Over to you, Lily.
So I don't necessarily have the background in holistic approaches, especially because I'm so deeply integrated into the medical field. But what I can speak on is bringing equality, as Robert broke up, into healthcare and healthcare access. You can look throughout. I only have a perspective on the US and healthcare since that's the system that I function in and the system that I work in on a daily basis. And what we can kind of look at is the way that healthcare and resources are distributed within the US. You can see, for example, the research that I was doing within my field was in the demographic distribution of healthcare associated infections and the decrease of healthcare associated infections as Medicaid was instated. There was a 12% decrease across the board. So it's really about access and providing people with the resources they need to get diagnoses, to get affordable health care, and to reach out to the resources that they need more than anything else. It's not really my field of expertise specifically. So there's not much more I can say on the topic. I'm sorry about that.
Thank you so much. Because we're just having a conversation. So you can also share your thoughts and not like scientific knowledge, but your own perspective and analysis. Over to you, Tahsin.
Well, basically, as a medical graduate and a current epidemiology student, I've started participating in some research studies, and one such study that I'm currently doing is a systematic review that tends to study the reasons. Basically, it tends to study if the cash transfer programs and the aid programs by the governments and nonprofit organizations, do they basically reach the child laborers or not? And one thing that we've found out is that most of the aid programs aimed for kids are being dispensed like at the schools by the governments, and child laborers, they mostly don't attend schools. So this is one instance that when the people who need to receive the aids are basically away from the place, basically the source from which it is dispensed. So that's one interesting point. And basically disparities exist in today's world, not only because of our lackings, but because how we build the systems to help the people. Sometimes we do not know who to target. when to target, where to target. There have been also studies, basically I'm doing the literature review for the study, and there were instances where United Nations, umbrella organizations wanted to help the people who were immigrants in the migration and refugee camps. And the thing that they found out was that no matter how much they helped the parents in terms of the nutrition of their newborn, very little output was being, sensed or detected because most of the people were illiterate. So in order to bring the bigger changes, it's not just the healthcare system. We have to make our aid programs, the help schemes, or whatever plans that we have, they must be customized for the setting that we're working on. So that's one really important factor, the customization, the preparation of each plan specific for that society, for that country, for that city. So that's one of our major findings. Thank you, everyone.
Thank you, Tahsin. Over to you, Callum.
I think the biggest thing policymakers need to do is, like everyone has said so far, is make everything really community based. The people making our policies tend to not be part of the communities they're making policies for. And even though they might be highly educated through academia or other means, it does not mean that they have that lived experience. And so they are missing out on different nuances, and that really just bringing in the community to hear what they need. But I think the biggest thing there is once you hear from the community, actually implementing what the community said. As many of us know, a lot of the time, we do have a voice, but that voice isn't implemented. We're just kind of listened to and said that maybe we'll do something about this. And then something that needs to also be done is really supporting and funding those social systems that help with the intersectionality aspect. So what by that I mean, for myself, as an example, I have really, really good health insurance, which I'm very grateful for. But as someone with a disability, I can't drive. So I haven't been able to get to any of my specialists in over a year because a lot of my specialists are over an hour, 2 hours away. Um, and so policymakers need to make policies that help have transportation for patients, um, help them out with daycare costs. That's a really big one. A lot of people can't go to the doctor because they have to watch their children. And other social systems like that really need more funding and support from our policymakers so that the system can work holistically.
Thank you so much. From the previous question, I think we've now touched on the healthcare disparities, where they stem from, and what the recommendations would be. And there's a World Health Organization conference coming up, I think in March or something. But it's been years, and health is one of the leading basic human rights, right? So what is it? Why is it that even after all these years, I'd like to think that the academia or the doctors or policymakers have an understanding of what needs to be done? What are those barriers to addressing those historical and systemic barriers? It's an open question. Anyone who feels they can go first.
Yes, the barriers, what I see today, it is now funding, because very many people, very many funders are from one-sided, one region, of which it is global north, and those people are concentrating where they can gain profits, or they are giving charities where they can gain something. So funding, it is the biggest barrier in breaking the historical system, And if it is addressed very well, the historical system is going to be addressed. For example, in funding, if in funding, very many funders, they have come out to give donation as charity. And when you quantify the charity in regards of the harm that they have caused or that is on the ground, it is not worse. And you find some people, they remain voiceless, they remain helpless, and they end up dying, some children. So we see if they can address the funding system in this place, it is a good output.
I think here in the United States, even though we are in 2025, the education just is not there. Especially for obviously older doctors and policymakers. It is not an education they were provided 10, 20 years ago. It's something that I think, in my experience from being in health, that it is something that is now being taught at a lot of universities, but it's still not widespread. And I think on top of that, healthcare doesn't tend to take an interdisciplinary approach. So it doesn't take in social sciences, psychology, anthropology, sociology, where our future of healthcare could be taking courses on African American studies, Indigenous studies. They aren't required to take those courses. A lot of universities don't even offer those courses. So I think it's just the fact that that education is lacking, and there isn't a lot of continuing education for those who are already in the field in this area. And if there is, there's not time for them to take it. We need to really provide healthcare professionals with time, which is very slim for them already, when they have to choose between seeing their family and sleeping versus taking more education. There's kind of that choice there. Um, but I think really healthcare, medical schools, public health, masters of public health, really need to require a social determinants of health and some type of course that teaches you about different cultures.
And I personally think that when it comes to overcoming the previous hurdles, one of the major issues we face is that we aren't quantifying the problems we are having. For instance, the issues and the challenges in the US may be of a different nature to ones you probably face in Asia or Africa or Europe. And also in the United States, the problems might be different among different ethnicities, like it could be different in different states. It could be different among the Asian ethnicities, among the Caucasians, among the African Americans. Some states are better off and their challenges might be different. On the other hand, some states may have more newcomers and they may have a total set of different challenges. So quantifying the challenges and determining everything statistically and laying out the goals is the most important aspect, not just laying out plans and starting schemes just for the sake of, publicity. I think it's important to really, really identify the problems and set out our goals, like what we are going to achieve with our schemes, with our plans. And if that happens, if we are clear about what we are going to do, I believe the governments, the not-profit organizations, and everyone else who is working towards a more just and well-balanced healthcare system will see more pronounced changes through their input. Thank you.
That's a really good point. It's really the root of the problem is that we are trying to find blanket solutions to distinguished problems because each group, each different race, religion, ethnicity, country, state, they all have their own socioeconomic factors which create unique and individual problems. And in the system we're in right now, we are not trying to address individual problems. We are trying to find blanket solutions to a non-generalized problem. And being able to address the specificity and really being able to find the specificity and the individualism in each different struggle that people are facing is what's most important for finding actual solutions, as opposed to summarizing the struggles that people are facing and expecting that this is somehow we will find a blanket way to solve everything. It's really about looking at individual experiences and circumstances and using that to shape the policies that we're putting in place. The problem is, though, that's a very difficult thing to do, especially when you live in a very diverse country. It's not easy. And that kind of goes back to Callum's point of we need to talk to and address, and we need perspectives of people who are facing these struggles, as opposed to expecting policymakers overall to determine and understand these struggles that they aren't experiencing, they're not witnessing, and they're not facing.
Thank you so much. I would imagine that like now I'm having a tongue twister because I'm feeling like I'm not well versed in medical science, but I can imagine that there are communities where they would like to implement local initiatives or interventions, but because of that limitation or lack of understanding. And I want to pose the question to each of you in your respective backgrounds and your respective expertise. How can you advocate, or what would you propose communities come up with in order to bridge the gap in between policymakers and somewhere making sure that they can get their needs met?
This is quite a difficult question because we currently, at least within the US, do not live in a system that is giving power to the people in that manner. The problem is it's such a deeply systemically ingrained issue because we have these systems that are enabling people coming from specific backgrounds to enter these positions of policy, and it's so much deeper than just listening to people or making it happen. It's looking at the way that we're distributing wealth and education and the resources that we're providing people with, and why we're not having people from these communities in positions of power and policy. It's so deep, and it starts really from the very beginning of how we treat people and these implicit biases that we have, and the education outreach that we're giving people. It's I need to collect my thoughts. It's very integral in our system that certain people receive certain resources to get them into certain positions, and we need to dismantle that structure and provide everybody with equal opportunities from the get-go and equal educational opportunities from the get-go so that we can diversify the people that we have in our positions of policy control. It's about addressing the root cause as opposed to assuming that if we kind of just listen to people more, that'll solve things. Because at the end of the day, it's never that simple. You're never going to find people that agree on everything entirely. And it's going to be very difficult to find people who both have the background they need to understand policy and the background in all of these different cultures and places. So it's really about dismantling the system we have in place now and providing everybody with equal and affordable educational opportunities so that we have a more diverse platform to reach out to and to speak with. Thank you.
Yes, thank you very much. Here, what I can say, it is to urge those people, those policymakers, to address the cause, not the symptom of the disease. Let's say climate is affecting us, for example, but all policymakers, they are targeting high temperature, but they are not targeting the cause, what caused the high temperature to rise. So in health, we better target the cause of the disease, or what we call etiology, and we address the disease. And here we need to think about prevention, protection, and promotion in public health. If we integrate those 3 Ps in public health and those policymakers get to understand if they integrate them in what they are doing and come out to address the cause, not the symptom and sign, we are most likely to solve the problem. Thank you.
Like Lily mentioned, it's in the US, it's a little harder than just to kind of listen and bring people in. But when we do bring people in, we need to make sure those voices are diverse across different ethnicities, abilities, economic statuses, and whatnot. And one of the biggest things that I've learned from working with indigenous communities is kind of twofold. One is when you do bring in people from these communities, they have expert knowledge. Just because they don't have the title of a master's degree or a PhD doesn't mean that they're not experts in their own lives and what is happening to them and their communities. And with that, you need to compensate them the same way you would compensate someone who has a PhD or who is a medical doctor for their knowledge. And also, as I mentioned earlier, there needs to be more than just listening. We can listen all day and we can write reports and everything like that. But if we're not actually implementing what these communities say, we just wasted their time and our time. And we really need to start moving from listening to one active listening. I think that's a big thing. There's a lot of rushing to listen and deadlines, and we only have 2 weeks to get this study done. But then we need to move to action. What did these communities say? How is it different than what we're actually doing right now? And how can we change the systems to implement community-based initiatives?
Tahsin, do you want to add anything, or I can ask?
Well, I believe that for overcoming the issues and presenting better solutions, you have to look at everything in a collective manner rather than considering bits and parts. And the issues that we are presenting must be representative of the entire society. The sampling that we do must be representative of the target population. So that is very important. And secondly, the policymakers are probably just a group of people, a group of politicians, like maybe a handful of people. So it's not, proper to expect a lot from them. The system must be rectified, the entire system. And rather than rectifying the issues from top to bottom, it must be bottom to top. It must be the people from the society, the poor people, the workers, the financially weaker sections of the people contributing. The knowledge must be increased. The people must be made more aware of what they have to expect and what their rights are. And they have to be encouraged to participate in various schemes that could benefit the collective good. And if that happens, and if the society comes together and if the triangle is made from top to bottom, I think the policymakers would automatically, would implement the changes that would provide the best outcome in terms of health equity. Thank you.
Thank you very much. You have just talked about, equity, education, access, and I believe these will empower communities to be able to be in a position to share their lived experiences, also document them in such a way that they can use them as advocacy tools. Now, our next question is, what is the most eye-opening experience you've had while working on these issues to address healthcare disparities?
So when I was carrying out my research, I can't provide exact numbers right now because I'm in the process of getting things published and working things through. But what I can say is when I was conducting research at the academic medical institution that I work at, it is a and I've done the training, I've gone through all of the onboarding. They place a lot of emphasis on implicit biases and understanding diversity and equitable care. And when I was doing this research on demographic disparities, especially racial disparities within hospital associated infections, the starkness of the results that I saw when you're looking at the hospital demographics compared to the demographics and the proportion that they took up of healthcare associated infections, especially in African American and Black people, was insane. It was something like 4 to 5% of the hospital population in general, and then 17% of HAIs, of healthcare associated infections. And that was a moment that really made me sit back. And I was like, wow, this place that I really highly regarded and respected as an institution that cares about everybody and puts patient care first still has such an insane disparity within healthcare. So I can't even imagine what it looks like in places that don't care so much about or put so much emphasis on disparities and equity. And when I was doing my retrospective analysis and when I was doing my literature review, what also really surprised me was that, sorry, I have the numbers pulled up right here. I'm trying to sort them out. So looking at socioeconomic disparities within healthcare, poor communication with primary care physicians was 266% higher in higher poverty, lower education areas compared to those that were quote unquote better off. So higher median income and higher educational rate. And just kind of seeing that lapse in outreach, especially to the communities that need it most, is crazy to me. It was really, really shocking and a very humbling thing to see. It really puts things into perspective. Thank you.
Yeah, my experience when I was working in the refugee settlement, we used the village health team, and of which village health team didn't have a immediate structure to reach the real beneficiaries on the ground in addressing the public health issues. Some children were still dying because of dying from malaria, from diarrheal diseases, from tropical diseases. And some political leaders from global north, they used to cut off the support to those afflicted communities. In 2016-17, if we still remember, the first term of the president of USA managed to cut off also the support to Africa, and very many people, they were affected health-wise. And some people, we lacked supplies, we lacked sundries to use, and there were very many outbreaks, Ebola, cholera, in the community, of which it affected very many people in the community, and some children, they died from those diseases, and malaria, it is still continuing. But when we started using women care group, we saw that this working together from the same geographical area in the group of 20 women working together to address the health issue. Let's say, if these children, they were dying from the diarrheal diseases, and the diarrheal diseases, they come as a result of poor hygiene in their home, poor hygiene in the water sources, poor hygiene from what they are from their daily community. But if they gather together and they share the idea in how they can maintain the cleanliness of their home, domestic hygiene, the water source, and the community, and also encourage them to sleep under mosquito nets, you find the diseases fluctuating, reducing. But it is not like the previous system where the VHTs, we are finding a VHT, one person in the community from the given area, but with very many people, and you find is not meeting the needs of the community. is leading. But these women care group, you find they are small groups from same geographical area working together to address the challenges. And you find there is voice, hearing the voice of everyone, equity in problem solving. So you find now the challenge is reducing. But the biggest challenge, it is in this world today, there is a gap where global north people, they tend to think that they are the one who are supposed to stay in this world alone, and other colors, they are not supposed to stay in this world. And you find they are trying to cut off the support going to support the affected people from the given communities. And you find we really work to save the lives, but in hardship, in a hard lack of supplies and not recognized. So we see if these policymakers, if they can revise their system of administration from top to down to bottom to up, it will be a great support. Thank you.
Thank you. So one thing I wanted to point out was that we speak about equity in healthcare and measures to, fight against disparities in healthcare. But something that I've come to learn is that the people who are providing the healthcare providers, are also really important. One thing I recently studied was the health of the healthcare providers, the people who are basically at the front and providing the healthcare services. Sometimes their well-being is being overlooked and ignored. This is especially more important in settings that are, tense and in a crisis. For example, when there is an immigrant crisis or when there's a war, the healthcare providers might be at a huge risk. So back in my country, in Bangladesh, there is a huge immigrant crisis. People from Myanmar, Burma, they are trying to move the Muslims from that country, have faced persecution in their country, and they have fled to Bangladesh, and they are placed in very tiny camps. A huge number of people live in a live in a tiny place, and plenty of international organizations have sought to bring together healthcare professionals to provide services to these people. But a study that has been performed on the healthcare professionals in these settings really elucidates the pressure that the healthcare professionals are exposed to. So the healthcare providers are the buffers, basically, between the policymakers and the people who we are targeting. So if they aren't feeling fine, if they are not having safety, if they are being targeted by the people, if they are living in a situation where their lives aren't safe. We see a lot of people from MSF, CADRI, the Medicine Sans Frontier. It's an international organization of doctors who provide healthcare services in areas that are not basically stable and in war or in crisis situations. So we see a lot of these people getting harmed, getting killed while they're providing service. And sometimes like they are in extreme anxiety, and that would really affect their performance. So it's really important to look after the well-being and the mental health of the healthcare providers as well, because if they aren't feeling well, no matter how good the policies are, no matter how good the policy makers decide, the changes will not be expected. So that's a really important issue that's sometimes overlooked. Thank you.
I think the biggest thing that sorry about the dog. But the biggest thing that I've experienced is that really just healthcare providers don't know. If it wasn't part of their basic education, which isn't their fault, they did their education. They really just weren't provided educational opportunities that either brought in different communities. For example, transgender communities, it might not be something that they reversed on, and a lot of the time they are only educated on basic diseases or other healthcare ailments. And then when someone comes in that is outside of kind of those check boxes, they don't really know what to do, and they can say that maybe it's just anxiety, diet, exercise. You need to just do the biggest thing I've heard my whole time with my disability is I need to do yoga and meditate. So things that like that just aren't there really in our medical system. And it leads to preventable diseases becoming exacerbated or becoming permanent chronic illnesses.
Wow. And thank you for our guest features. I mean, your dogs. I was really feeling sad about, you guys' experiences. That, we tend to be closed in and think that the problem is one-sided, or say, I know in the communities that I work with that hygiene, basic healthcare is limited because of resources, that we have this closed in, and now realizing that the problem is much bigger than that, not just systemic barriers, and that even the healthcare professionals lack the resources and support to be in certain areas, to be providing the support that they need for their patients, and to be in, for example, conflict war zones, and not knowing whether they'll make it back home, but still be expected to be providing quality service. It's just heartbreaking, and thinking about all the other problems that are going on in the world. But I have hope, and I believe that you guys have hope as well. So we'll be wrapping up, and what is one hope or one thought that you have that we can achieve health equity despite today's challenges, or any recommendations?
Yes, what I can do, it is to use the system available to address the challenge, to use the resource available to address the challenge, and also try to help my community raise their voices to the voices to those policymakers to hear, because sometimes you might find that those policymakers, they might be sitting in those meetings, but they don't know that there are some people suffering from the affected world. That's what I can imagine. And my role now, it is to continue uplifting those voices to the affected, voices from the affected communities to the world, where people can understand and see how they can fix the challenge, and admit that they need to support, they need to bridge the gap that has been in place. That's what I can do. However, we continue calling for support. We need to continue urging them to accept and support us to fill the gap, not to treat the symptom and forget the sign, forget the cause, sorry. So if we can work together in this, it is going to help us. Thank you.
I think that one of the things, the question was regarding what gives us hope for healthcare systems, right? Yeah. So I think that kind of one of the things that really, especially as a young person working in healthcare in America, gives me hope is the fact that our system is constantly changing and developing. And the fact that we're even able to sit here and have conversations and address these disparities is such a huge step from where we were at 50 years ago, from where we were at 100 years ago. And we do not live in a perfect system by any means. There is so much improvement that needs to be done, and there are so many issues with the way that things are now. But every day and every year, maybe not under this presidency, but in general, we are progressing as a society and as a people. And we are constantly working together to improve things. We know that these problems exist, and we are allowed to address these issues. We are allowed to try and fix these health disparities, which is something we didn't have in the past. This wasn't something anybody cared about or even took time to notice. And not that nobody cared about it. That was bad phrasing. That's not what I meant. But it was something that, the general public did not bring their attention to. And the fact that we're able to speak about it, and we still see, yes, there's still horrible healthcare disparities regarding race in healthcare associated infections. They're much less than they were 10, 15, 20 years ago because we're continuing to educate and bring attention to the topic. And as long as people remain hopeful and they remain educated and they continue to reach out and try to make a change, we are going to progress. That's what it boils down to. The more people know about this and the more people care, we are going to keep progressing. And that's kind of just what keeps us going, I think, through these tough times, is knowing that at the end of the day, every little thing we do makes a difference because we're bringing more attention to an issue and we're educating more people. Thank you.
Well, the fact that we are having this conversation now and the fact that we have identified the issue of health disparity is the biggest step towards fixing it. We've basically identified the issue, and also the fact that there are various organizations that are seeking to raise awareness, that are working to help the people in need. That's really very much heartwarming. There may be issues, there may be various problems in implementing the plans, but we are on the right track because we have identified the problem. We know what we are dealing with and what changes we have to expect. And I think the fact that we are aware of the issues and we are working towards it is the biggest stride that we could have ever taken to fixing this issue.
I think what brings me hope is that our communities continue to fight. Not just healthcare providers, but regular old community members are educating themselves on health disparities of other communities that aren't themselves. They're teaching others about them, their communities, and there's community organizations, there's activists all out there really fighting for equity in healthcare. And I think just that fight's continuing and growing is really helpful.
I agree. I think that with every generation, we make more of an effort to educate and to sort of inform. And with each generation, right now, I'm part of a generation that's being, when I'm in pre-med, I need to take classes that involve understanding the ethics of healthcare. I need to take classes that involve understanding demographic disparities. It's integrated into my education right now. And that's information that I'm learning from the previous generation, and I'm going to pass on to a further generation, which is going to take that and do more with it. So it's kind of being able to pass on this information from generation to generation and build upon it is really, really the foundation of how we're going to progress. Because that's kind of, I guess, the thing I can credit Gen Z with is is the way to phrase that, is that people, especially with social media, which can be used so powerfully to spread information, people actually care and actually want to make a difference. And we get to continue building on that. And that's what I get to teach my children someday. And that's what I get to teach the next generation of physicians someday when I make it through medical school, if I make it through medical school. That's what I get to pass on to people. And I think that's kind of the beauty of it, is that we get to continue growing because this is the mindset and these are the values that we're bringing with us and that we're passing on.
Thank you so much. Tahsin, did you want to share anything else?
No, I think
I saw that I saw that your mic was unmuted, so I thought you wanted to share. Thank you so much for the work that you're doing. I appreciate also, and I believe that the audience is also appreciating the insights and the key takeaways that they've gotten from you. We've really dissected the issue here, and I'm feeling inspired to go and learn myself and use the knowledge that I'm going to gather to share with my communities, and hope to inspire more conversations on this, and hope it lands somewhere and it inspires change. And I believe from this conversation as well that we are going to start moving in a united and more harmonized way, knowing that we're not alone in our own respective challenges. If we don't have any other last words, then I'll bring in Yana, who'll do the closing for us.
Wow. This was very impressive. Thato, thank you for your wonderful work here with your questions and bringing out all these important comments. Robert, you are so dedicated in helping people in your country and your communities, working with refugees, and all the work that you do. You're incredibly amazing. Tahsin, your work and study ethics are so impressive, and your focus and your work with now with us with We the World, as Robert does. Lily, the same. I know we were all better with you and people like Tahsin doing the work that you're doing, and wish the both of you so much luck and good wishes and congratulations for what you're doing and what I know you will do in the future. Callum, you are so amazing. You have been with We. You helped us get a lot of places that we're still trying to get to, and you continue to amaze us and encourage us and inspire us with the work that you're doing. And I know you've been through so much, and yet keep you keep on chugging along and doing incredible work. Thank you, all of you, for being here. Your presence is very, very important. Your thoughts are so thoughtful and inspiring and important, and we really appreciate it. Thank you to Birgit Ben-Eli for her work in bringing this event together and for all the work that it took to get everybody here today in one place at the same time, one virtual place, I should say, and also for being my tech assistant for today. Thank you to all of us, to all of you in the audience, and us too for listening and for joining our broadcast today. Remember to please join us and take action to be of service at we.net/MLK, and donations are gratefully appreciated and welcome at we.net/donate. And now, goodbye from all of us at We the World.